Good afternoon, welcome everyone, and thank you for joining us for today's education session, dealing with the Delta strain and infection control update. My name is Charles Broadfoot and I'm one of the Professional Development Officers with Hunter New England Central Coast Primary Health Network. And I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands in which we are meeting on this afternoon, pay my respects to elders past, present and emerging, and also welcome any and all of our Aboriginal friends and colleagues who might be joining us online. So today's session is being recorded. We have extended today's session by 30 minutes. Thank you very much, Marg, for spending more time with us today. We have had a lot of registrants for this event and we're getting a lot of questions through our education events around PPE and infection control. So if you're not able to stay for the extra 30 minutes, just be assured that the whole session is being recorded and this will become available from this afternoon in our PHN Education Library on our website. So to access this and our other recordings, you just head to our homepage, thepHN.com.au, and click on the Education tab. Today's session is also being evaluated, so we'd love your feedback. A survey will automatically pop up when the webinar ends today. So if you could just take a moment to fill that out before you log off, that would be great. You can type your questions in at any time throughout today's presentation in the questions box in your control panel. We have allocated time as well at the end of Marg's presentation, but she's happy for me to jump in if you have any pressing questions while she's presenting. So now it's my pleasure to introduce today's expert speaker and friend of the PHN, Margaret Jennings. So Marg is a microbiologist and infection prevention and control educator. Thank you very much. We've got a visitor there behind you, Marg. I'll hand over to you to kick off the presentation.
Thank you, Charles. I've just been delivered a cup of tea. And
perfect timing.
I haven't checked to see that I've got all the parsley salad out of my mouth. So, all right, you can tell me. Now, it's lunchtime. Fine. It's lunchtime and it's Thursday, and you guys say to me, I didn't sign up for this last year. Well, this is the situation we're in. So there's no point belly aching about governments. Everybody's doing what they can. So, let's not pay out. Today's the chance for me to make life as safe as I can for you. And I'm very big on us, seeing our patients. Okay, I'm very big on that. So if you thought today was all about, oh, she's just going to say, telehealth, no way. Telehealth is important and we do it when we can, but there are some things we should not miss. And that is about making sure that our patients have got, a bit of oxygen in their system. And if they need to go to hospital, that they go earlier. You would have heard Kerry Chance say that the other day, that some people were just getting to hospital too late. Now, I'm aware that there are cases in Armidale, etc., and I'm praying little Morpeth in the Hunter Valley. I don't want to hear that there are any cases there, but you can tell me, Morpeth. I know a few of the practices in that area, and I'm thinking of Inverell too, outside of beyond Armidale, etc. So I'm really hoping that we haven't quite got there. And I've always said that you're only ever one Qantas Link flight away or one Uber driver away from a case. So I think one of the hardest things is actually saying to yourself, I am in the middle of a global pandemic, because we are so good as humans as assessing our risk as low. We all assess our personal risk as low. That's human. So let's just, toss that one to one side, because I'm here to say to you, you're in the middle of a global pandemic. What part of that are we not understanding? So I'm going to bark some orders to you today. Easy for me to do. I love telling people what to do. But this is what you're just rereading and I just said to Charles, I get mixed up with the Intergovernmental Panel on Climate Change and the other one that tells us what to do with COVID. So sorry about that, but I'm talking about the National Committee that gets together on COVID and tells us what to do. So just rereading that before is a bit of a freshen up. It says, PPE number 3. It says think about your engineering and administrative controls before you even think about PPE. When I had a look at the questions Charles sent me yesterday from a clinical meeting that you guys had, a couple of nights ago, I thought, yeah, we need to get our heads around what is it that I'm doing in my clinic. So let's look at our clinics. And if you said to me, Mark, do you think 1.5 metres distance apart in the waiting room is enough? I'm going to explode. Because the first question I'm going to ask is, why are you using your waiting room? So you can all look shocked at each other and say, oh my God, what's she saying? But first of all, 1.5 metres does not cut it. So with Delta, what have we learned? We've learned a few things over the last 18 months, and we've learned a few things about Delta in the last, 4 or 5 months. So what we've learned generally is that, and accepted, that this is in fact airborne spread in particular situations. So not so much outdoor, and that gives us a huge clue as to how we can actually conduct a lot of our medicine. Good medicine can be conducted outside, and that is what I'm going to be recommending as much as we can. And where I do have to examine the patient, do I really need to sit with them right next to them while I discuss things? No, I can walk them back to their car and have a chat. Can I do a wound dressing in a car? You betcha. So the pandemic model, as well as saying, look at engineering and administration, no handling of cash, please. As well as looking at that, it also says, look at developing an alternative creative model for your care. And I don't think that automatically means telehealth. Of course, do as much telehealth on a particular person as you can, but at some point, that's not going to be satisfying enough. And you go, you know what, that patient needs to come in. So for some patients, it's no more than telehealth. And for some patients, it's actually a mixture of, I think you need to come in, but you know what, I'm going to see you in your car. And then you don't have to clobber up, put all your gear on as much. You've got to stick your head in a patient's car who's got symptoms. Sorry, I've got the P2 mask on and the face shield. I'm not getting that close. But we do know that outside affords us generally, and I think it's pretty windy up there, generally outside affords us just unlimited air changes. So let's now get a hold of this idea of airborne. So I want you to picture 6 patients in your waiting room, very naughty, and you're saying to me, Mark, I'm doing the right thing. My 2 receptionists have each got their masks on. And I go, why have you got 2 receptionists? Oh, well, one answers the phone and the other attends to the patients. Get the one on the phone into a room on his or her own. I only want 1 receptionist there. I told you I was going to bark orders. These are all the things we can do to reduce risk. So if you say to me, oh, I want to put P2 masks on my receptionists, you've got the bull by the wrong end, okay? So look at, where are my risk levers, up and down? And you've heard me bang on about this before, but we know a lot more now. It's not enough to have a screen. It's not enough to wear a mask. What can I do? Well, if the patient has to come inside, they come straight through from their car to the doctor's room, preferably even the treatment room. I love the doctors not having any patients in there. So they can, set up a coffee machine or a thermos, do their telehealth, no masks, fabulous. Got to think about mental health. So at a number of clinics, I'm in Melbourne, as you know, and I'll tell you what, we're used to this sort of lockdown. I don't even understand. For me, there's no difference. Okay, I'm in lockdown, 5Ks, no one to your house, blah, blah, blah. So you can say, I've got to be able to live through this. I've got to be able to deliver my medicine. So how can I work within my office? Because this is my comfort zone. Nobody else is going to come in. And if I need to see patients, I'm going to see them in my treatment room. So this is one model that I'm proposing. I can see the patients in the car, but no, whoops, they've got to come in for an exam. So a lot of treatment rooms actually have an external door. Fantastic. So the patient comes in that way, and you might have 2 or 3 cubicles. They're in for the shortest time for the examination, and yeah, walk them out to the car. Have a discussion out there in the car park. I think you've seen a lot more written about, privacy and how we can kind of really, deliver medicine and not have that huge sort of impost, to sort of shout advice in the car park, but to deliver medicine with that alternative model. If you've got to get close up, you've got to get close up. If the patient is a suspect, I don't want them inside your clinic. And I did hear on the Gold Coast on the telly a little while back that one of the Gold Coast doctors, I'm a little bit antsy about this, but she said, oh, the patient, I thought, oh, he's got some symptoms. Why was that patient in there? So engineering, I mentioned, administrative, and then PPE. Let me now look at administrative. I've suggested really paring down use of the waiting room. Now, sometimes my biggest arguments are not with the doctors, they're with the managers. Oh, we can't do that. And I go, well, what part of a global pandemic are you not getting? You know, I'm a bit rude. Because you see, their focus is on, this is my business, these are my patients, I've got to care for them, I've got to keep doing everything as I did. So the poor old managers are not used to infection control or budgets or that kind of thing for infection, but they are now. They're on board. A lot of them are working from home. I know that because I have a lot to do with them. So no, we're not going to be using the waiting room. This is if you're going to follow, you know, my suggestions for reducing risk. If a patient is being seen, it can be telehealth first, but no, if that's no good, then yeah, come in, I'm going to see you in the car. Whoops, I need to examine you, come on inside. You see how you can, because every time you reduce close contact, you reduce risk. Don't get it into your heads that, oh, well, you know, what's the difference? I've got to see them all anyway, and they're all inside. But every time you reduce time, you reduce risk. And that's what you need to, you know, that's the space that I've had to work in, you know, as a microbiologist. You know, I was thinking about when I was working in a virology lab some time back, and I'm going to tell you, there were some viruses, we couldn't even get them to grow. And I was thinking, stupid old, you know, SARS-CoV-2, you can't stop it. But, you know, we're so used to going back into the lab on a morning and you go to sort of tip off and replenish the medium. Oh, they've all died. Gee, I wish I could remember what that thing was that killed them all, because, you know, that's what we need down our throat, don't we? So here's this thing. It's only looking for your throat. It's going to find it. So it's looking for the receptor sites on your throat, to a smaller degree your eye, you know, lungs and gut, etc. So administrative, we can reduce our risk. We can send the patients a receipt. We can do stuff by email. They can post money in, for God's sakes, if they're desperate. But that's the admin bit. I've only got one person in reception and they're welcoming patients through to the doctor, those who need to go through. If they're welcoming them in through the back door, they're outside welcoming them in by the back door into the treatment room. The patients are not waiting, they're not congregating. So to get this picture of how this thing is spread, I want you to picture a COVID ward. Haven't been able to give people maybe individual rooms and things are getting tight in Sydney at present, and probably in Newcastle too. So I want you to picture these 4 people, let's say, shared room, breathing, too crook to put masks on, and they've probably got other bits and pieces on their faces. So there's a fair viral load hanging in that room. Now let's say this is one of the naughty hospitals that doesn't have 4 to 6 air changes per hour. Any of you got that? No. We don't do that in general practice, but we do have open windows and doors, don't we? Please don't tell me that you've got a closed thing, you know, with God knows what heating happening and everybody huddled together. It's not going to work. So I want you to picture this room with the 4 patients in there, and they're breathing. You know, they're normal, they're alive, and they're breathing. And I now want you to picture there's not much air moving. And what I'm now getting is a suspension of hanging tiny particles of spit and snot, you know, wet particles, but hanging. Tiny ones hang. The large ones hit the deck pretty much straight away when somebody coughs, but these small ones, but they're congregating and the person keeps on breathing. So there's more and more, and there's 4 patients. And then you walk into that room. Well, guess what you're going to be inhaling? And if you're wearing a surgical mask, it won't be enough either. So this is the situation that we are facing when we are close up to somebody who is positive. Your thing is you don't know who's positive, but who is positive, and this stuff is just accumulating. So you can see why there's been a huge concentration on the engineering. So this is the engineering part. So you go, what am I supposed to do? You know, we're in a little converted house that's our clinic. You know, what are we supposed to do? Run off and get, you know, spend $50,000? No. So you can par this down and you can say, I'm going to reduce the amount of time spent inside close. And by close, I mean even in that room. I'm not going to do the 1.5 metres, no way. It's not going to cut the mustard. You can see the problem is, are the tiny, tiny, tiny bits, particles of spit and snot, are they hanging? Of course they are if you've got 6 people in the room and you're in the middle of an outbreak. Now, so that's one thing that you can do is open your windows and doors. The other thing, if you're filthy rich, is to run out and buy an air purifier, Samsung, etc. There's a bit of work being done on those at present. And in fact, in the Royal Melbourne, in the outbreak, you know, where we had a lot of aged care people, the care homes affected in Melbourne last year, and they just decided to bring the patients inside because they were so crook and just the care level wasn't fantastic because the staff were crook too. They brought them into the Royal Melbourne and they actually started to use those HEPA filtered Samsung, well, not just Samsung, but there are other brands. They're about $700 each. But, you know, if I was working in, say, a treatment room where I've got 2 or 3 patients in cubicles at any one time, I'd probably, you know, go for one of those. Now, before you all hit the, you know, purchase button, if you go to Godfrey's and, you know, probably Harvey Normal and, you know, whatever the other places are, Bunnings, they only really stock maybe 2 or 3 at a time. So don't sort of disappear yet. That's one thing that you can do, and they have done some work in the School of Engineering to show that. And in fact, our Chief Health Officer, Brett Sutton, was on the telly the other day, you know, when they give their daily report, talking about that engineering. So that would work for, I think it's a 6 metre by 10 metre space. You have all the doors closed actually because it's purifying the air in that space. So that would make life safer for you where the patient has got to come inside. But you wouldn't just say, I'm going to put one in the waiting room because it's probably a huge impost on your poor little thingy. One of the biggest things you can do, and please never, never, never underestimate this, is the questions, are the questions. So firstly, it starts with you. When you woke up this morning, did you do a check on yourself? This is like gold. It takes like 10 seconds and people kind of just brush it over. But I have to tell you, and this is one of the questions that was sent to me, I have to tell you, you will thank your lucky stars the day that you questioned yourself in the morning. You were okay, and I'll go through the symptoms in a minute. And by the way, they're changing a little bit with vaccinated people and also with Delta. So we've got more of a runny nose thing happening. Cough, I think, has dropped down a bit to sort of 4 and 5, but runny nose is a little bit up there, also with the vaccinated people, and we know that they are shedding. The problem with Delta is the infectious dose looks like it's about 2 log less than the other, you know, it's really, and it just loves your throat. So the receptors on your throat, it just love it, and into your system. So thinking about waking up this morning, and I really want you to get into this because I'll be a little bit upset if we didn't. So you wake up, no, I don't have a, some people need, you know, a couple of drinks before they can work out how their throat is. I don't mean alcohol. So have a drink. Yeah, I feel like, and I feel okay. That's one thing. No headache. Headache is prominent at present with Delta and also immunised people. So headache, no cough, no sore throat. Often you don't know about your own fever. So you go to work, but don't go inside. Have a buddy, check each other again and do a temperature check. So only about 45% of people in you know, last year's and this year's are really cracking a fever. And of course, you know that with the elderly, it's even less likely. I think they're down to about 33%. So for those clinics who just thought it was enough to ask a person, are you okay? And we're doing a temperature check, not enough. Let's get a bit more serious. So now going back to you, you need to know the health status of the people in your household, your bubble. So that 15-year-old who hides in their cave, you need to tell them that you are a healthcare worker. Excuse me, this is tea, not alcohol. I've already been picked up once for drinking live. You need to ask or tell your household that as a healthcare worker, you need to know if there's any sore throats in the house, if there's any runny noses, if there's any this, any that. 10 seconds, 10 seconds a day. Everybody at dinner. Okay, everybody, you will tell me, won't you, in the morning before I leave for work? 10 seconds. This is gold because we go back time and time and time again when we're contact tracing, and guess what? Yeah, 15-year-old in the house living in their cave didn't tell me that, you know, they were going through the Panadol and all that sort of stuff till about 3 days later. So we're into, this is called infection prevention and control. So that's the space we're operating in. So your household, don't come to work if anybody in your house has a cold. No. Or what about this one? You've got a cold. Oh, but Mark, you know, I've had a COVID test, I'm fine. Well, sorry, what are you doing here with a cold? Could be RSV, it could be flu, you know, it could turn out to be anything like that, might not be a cold. So I actually don't want anybody turning up to work with any symptoms. Thank you very much. Otherwise, we have learned nothing from this pandemic. And if we don't take the stuff we've learned, you know, we're stupid, we're no recall. So I can also say, same with our patients. So you've got to have Nurse Ratchet at the front. Anybody coming through, I'm going to be checking their symptoms. They're not coming in, and the doctor can go out and examine them because these people need to be seen. They may need to be off to hospital. And I really do want you to see your patients, and we need to see the patients for lots of other things. Now, one of the doctors, I think in Southwest Sydney, said the patient had turned up for an unrelated issue. And as the doctor was speaking to the patient, the doctor said, my God, this patient's got symptoms, had not been picked up. Don't be in that situation. Now, Charles, any questions to date while I just gulp this? And then I want to talk about how you can turn your consulting room into a coffee room.
I think one that you've sort of semi already addressed, Marg, was does the Delta variant have different symptoms? Did you want to talk about that a little bit more, what the differences are in this strain?
Yeah, my reference is Professor Tim Spector, who runs the Zoe project in England. I'm sure a lot of you, he's good, he's really good. So he's actually able to alert the NHS there because thousands of people get onto his symptom tracker, and he runs this through London University, one of the universities in London. So he's not sort of, you know, an outlier. And he said, you know, there's been a change in the symptoms, and there's also been a change in, and I think we picked this up in Australia, maybe a 3-day average incubation period compared to a 5-day. Not to say that you can't get still 13 and 14 days. We know that a tiny, tiny number, even outside the 14 days, but we've got to be realistic. So we're still saying 1 to 14 days, but it looks like we're getting a shorter incubation period, which doesn't help our contact tracers because those poor buggers are behind the 8 ball as it is at present. So thank God we're not dealing with something that's got like a 12-hour incubation period because you couldn't contact trace. You couldn't. So the symptoms there is headache is dominant, sore throat, the runny nose is right up there. So I'm kind of thinking of the top 3 or 4, and you know it goes right down to loss of, you know, sense of smell might be in number 6 or something. Cough may be a little bit higher, but cough looks to be just changing a bit. But certainly the runny nose is coming through. And when I see runny nose, I see loads of viral shedding. As a microbiologist, that's exactly what I see. So that's my reference there, Tim Spector. If any of you had a chance to listen to Radio National this morning from say about 6:30 to 7:30, you would have heard 3 brilliant interviews. So Cyril Khan from Israel, he's an immunologist. You would have heard, this is Norman Swan is to me the carrier of information. He's not the the starter. He's a great carrier. So Cyril Khan. there was Juliet O'Brien. I don't know whether you guys hook into covidlive.com every morning, but I absolutely do. So I'm always looking at all the different states' unlinked cases. I do get upset at the number of cases, but it's the unlinked that are the clue as to what we've missed. And, you know, we're dealing with, I think, 5. Don't laugh, I know, 5. But there's 5 popped up in Melbourne. And it usually means we've missed upstream, you know, going back a couple of cycles of transmission. We've missed one about 2 weeks back. So can I just say, contact tracing and testing did not actually stop a pandemic. They tell us where it is. There's only one thing that stops it. You staying in the one place. The virus doesn't move, we move it. We know that 90% of people doing the right thing, which means everybody except our emergency people and yourselves, we can control it. End of story. Okay, but we know what's going on. Any other questions there, Charles?
I think there's maybe just one more before we keep going. Thank you everyone for sending in your questions, but this one is relevant to what you were talking around airflow. It's come in from one of our practice managers. What happens when your surgery is in a shopping centre without any windows? So they have the centre air conditioning on the whole day. What are your suggestions?
Okay, number one, make great use of the area outside the immediate door, and the shopping centre will just hate you forever for doing that. But you know what? The shopping centres need to understand we're in the middle of a global pandemic. Number two, really upset them by saying how many air changes per hour in my place. And number three, and don't laugh, number of clinics are looking for somewhere else to establish, because this thing is not going away, not in the next couple of months. And so I've had a number of clinics say, we've actually moved from a from a shared air thing. We're looking at seriously moving, and we've got a nice big car park, and that's where we're going to see our patients. For the multi-storey clinics, you know, I see clinics that are on, say, but I deal with clinics that are on, you know, the 12th floor. And I've said, well, sorry, haven't you got a car park downstairs? Oh, but, you know, we can't see patients there, sorry. You need to get some space so you can see your patients there. And at least that's a screen before they get into the lift. Having said all that to my practice manager, we are not going to pick up about, say, 30–40% of cases. Okay, so what I'm saying there is people who may be in the pre-symptomatic phase, or people who just simply don't show symptoms. And in viral infections, this is very common anyway, to have people who just never express symptoms. But by people wearing masks, distancing, staying outside, you've covered yourself largely for that group. But it's when you are in the middle of a global outbreak, which you are in that area where you are, we know where the risks are, and they're where people congregate. So when you're having people phone up, don't just ask questions on the day, it's before they come in, because things change. And those of you who are giving immunisations, for heaven's sakes, please don't turn your immunisation clinic into a super spreading event. At my clinic, you're immunised right near the door, and you sit outside the door. So I can tell you, marquees are walking out of Bunnings, and it might be winter, but this is what we're dealing with. Now, can I actually put a plug in before I show you how to put on a P2 mask and talk about these? Can I just do a bit of a plug for mental health? And I'm in the, lucky situation of just returning from 4 weeks in outback Queensland. Don't ask me how, but I managed to fly out between lockdowns here and fly in before the last one was called, 4 hours before it. It's another world where I've been. They hate Victorians, but I've met a lot of New South Wales people, and people just really haven't got a grasp on what it is, that you guys are going through. So I do, but I really appreciated that time away, and just got back in from Cairns before, Code Red. So this is what I can tell you. Wearing a mask is not easy. And I'm now talking to the managers. if a mask gets wet, which it will do after a couple of hours, it won't work. I know that there is stuff written about being able to wear masks for 4 hours. Well, good luck. Bit heroic. But I'd be a little bit shocked if I didn't have each staff going through about 4 masks a day. Bit shocked. Because this is more than just about the mask working. This is about my staff not resigning. That's what this is about, and about them not putting themselves at risk. So if I were the manager, get stuck into our big check before anybody walks in. Sorry about the tea room, everybody. You either bring a flask, but please, 10 o'clock, 10:15, I'm going to be telling you, you've got to have 10 minutes off. And that 10 minutes is about mask off, toilet, obviously do your hands, grab a drink, go and sit in your car. And if you think that's unreal, then I think I know what the alternative is. The alternative is you're continually touching your mask, you're taking it off, and the only place for a mask that's taken off is the bin. None of this under the tracheotomy, placement. You've got to have a car to sit in every couple of hours, or an outside place. If you don't have to wear your masks outside, we do currently this week in Melbourne. But if you don't have to wear your mask, just get away. Now, for the doctors and nurses continually seeing patients, your patients would be a lot happier to wait in their car for the 10 minutes while you have that bit of a break. So I really want the practice managers to tap their staff on the shoulder, time's up, somewhere between 2 and 3 hours. Mix it like that, even 1.5 to 3 hours. Cycle through. You're going to have a break in between. Patients aren't waiting in the waiting room. They're in their car. They're very happy. They've got their radio on. They've got their phones. They're chatting away happily. I want you to go out and do the same in your car. Or what about this? One of my very clever clinics in Melbourne, they must have bags of money, but what they did was they have the treatment room with the 3 cubicles and the door to outside. They also set up a marquee to do, blood pressure. I don't know whether blood pressure work's being taken in the cold outside. I don't know. I'm not a nurse or a doctor. What they did was all the doctors used their room as their private space, no masks, and they had a coffee machine, each of them in each room. And they said mental health wise, this allowed them to navigate and work well. They could do their reading, they could chat to their patients, and to examine the patients, they'd put on their PPE and either go outside or go into the treatment room. But you need that space. I can't imagine a GP, I really can't, operating, working in this space with shared patients, 30 odd or more patients coming through a day. That is really high risk, I'm sorry. Even if you say, I open the door, open the window, etc., please just be a little bit kinder to yourselves. But do make sure we see those patients, because there might be somebody we need to send off to hospital, because we know some patients, as I mentioned, are coming too late. All right, now, I've got to do something about these. Now, can I say, and I can send this, I think this letter can be sent, everywhere, but a letter has arrived with healthcare providers in Victoria from our state government to say they're swinging over to a different type of P2 mask, and it's not the one I've got. This is just a Halyard duckbill, but it's that flat one, the pouch mask, 3M. And they're changing from one type of 3M pouch to another. And they're actually wanting all the hospitals, I think this is mainly to the hospitals, to get on board with this newer type or this different type, because the fit testing is a lot more successful. So let me now explain. I'm going to show you how to fit check. This is what you guys can do yourselves. If I've got to stick my head in somebody's car who's symptomatic, I've got a P2 on. No question. But because you may not have current access to fit testing, and please, I want you to explore this with your PHN, the type of mask that you wear is the one that you'll be fit tested for. But every time you put it on, you'll perform a fresh one, you'll perform what we call a fit check. So we don't have strong differences in safety between one that's only fit checked and one that's fit checked and you've been fit tested for. But let me explain the fit check. So here it is, it's got 2 strings on it. Never, ever, ever wear a P2, and they're often called a respirator mask. Never wear a P2 that clips around your ears. Not correct, because as you move your face, you will crack the seal. So 2 rubber strings, do your hands first. If I mention alcohol today, right, so always no jewellery. What's the point of having jewellery? All it's going to do is stop the alcohol getting to all bits of your skin. What I want you to think about with the alcohol is it is destroying the envelope of the virus. And of course, attached to the envelope are those horrible spikes, all right? And so I have to visualise when I'm using my alcohol, I am destroying the envelope and therefore the spikes. Fantastic. And the spikes are what attach to my throat. Every time you do your hands, I want you to think like that. So never like that. That's rubbish. All right, it's always 2 hands. All right, I'm not going to tell you how much, but what I am going to say to you is that the amount you've used, I dip my fingers in to get behind my fingernails, short nails. Now I spread it all over my hands, glistening wet. Now I rub it in and I keep rubbing until it's sticky. And if that is less than 20 seconds, I've not disrupted the envelope of the virus enough, and off the virus goes again. So just there now. Okay, hopefully that was 20 seconds, and you can't get your gloves on until everything's nice and dry. Just a little bit more of a word before I put my P2 mask on. Hand cream. So you use the same brand, whatever alcohol you're using, you use its mate, the hand cream. When you use your hand cream, it's a barrier cream. When you come in the morning, we actually start our work with a hand wash. When you wash your hands, get stuck into the hand cream, and you are effectively it's a barrier cream, and it's an emollient, which is a skin softener. Got enough problems with skin without, adding to it. This will protect your skin for those, multiple hand hygiene that you do. So get stuck into it. Then when you have your break again, your magical break at 10:30 or 11, you wash your hands, you go into the loo, wash your hands, etc. Get stuck back into it. Sit in the car, work it in, something like that. Don't just get anything crappy off the shelf from, Kmart or Woolies, but this stuff is as cheap as chips. This is the $11 for 500 mils, for heaven's sakes, cheap. So you need to protect your skin. But can I give you another tip? With your masks, I feel like I'm doing an ad for, I don't know, Long Con. Put it over your face, because your poor old nose bridge and eyes are not used to this much pressure, especially if you're going to be using the P2 masks. Hopefully that's helped. Now, having said that, and you use your hand cream 2 to 4 times a day, definitely first and last thing of the day, and then a couple of times during the day. But get stuck into it, load up early in the day, because that will increase the amount of softening of skin. Now, to put this on, it's got a nose, so you can feel the bread tie, I call it. That's at the top. So pop your beak into it. Now, if you've got hair like mine, you might consider a cat. All right, just for neatness, that's all. So here, no hair. 1 on the crown, 1 below the ears. 1/3 of the way down the nose, over the nose bridge. Now, press. You can see now why the cream is such a good idea and why a hairnet would be a good idea with my hair. I can do a bit better. What I do is I press it and I yawn and just give it a bit more of a nip. Now breathe. Good. I've got a seal happening. This is called a fit check. To have a fit test done, which is, the gold standard, which, you can't get all the time, is I won't say they put a bag over your head, but what they do is they measure any air leaks. And so some people just doesn't fit their face, that particular mask. And so they have to actually use a different type of mask or put on weight, whatever, or lose weight. Can't have a beard with this, I think you can see. So sorry, either quit work and, you know, grow grapes or shave your beard off. Now to take it off, grab the two away and down. Don't rip anything off, away and down. You can again wear these for a couple of hours. Now I know they made people wear them for 4 hours and stuff like that, but the makeup of these is quite different to that of the surgical mask. So the surgical mask, I've got 3 layers. I've cut this one up. So I've got that front layer, always wear colour out, always, always, always. The middle layer there feels like skin. Maybe you can cut one to show everybody at work, but they'll probably kill you if they're precious. There, it feels like skin. So this is what's going to protect me. But to wear your surgical masks properly, you're actually supposed to put them on like that, hands done, of course, and then. Now what you never do is twist, because now you've got a pocket and the air, rather than coming through here when you breathe in, now slips in through the other side. So you want it nice and flat. And you see how I've made it like that. That's the way to wear your surgical mask. Now, every time you touch it, sorry, you've got to do your hands. To take it off, there's only one way, both and down. How many people do you want to tap on the shoulder in the street and say, are you a mouth breather? Tracheotomy. Probably this is the least controversial. This is the I'm having a coffee. All right, enough of that. But for you guys, you're healthcare workers, so life's a bit different. So I wanted to show you the P2, the correct use of it, and how important it is to protect your skin and get that seal, because, and I'll send this to Charles, the letter that I've, you know, not sent to me, but for healthcare workers at hospitals in Victoria, is that this particular type of mask that they're procuring has got a better, how can I put it, rate of passing the fit test. I don't know whether you know, but last year, oh my God, they had stuff come in that like 90% were failing because you just couldn't get a good seal. So there's this particular one, 3M, and look, there are probably others too, but this is an acknowledgement that this is an airborne infection. So I can ask you now, what differences can you make to making life safer for you, your staff, and your patients? And that includes senior patients. How can you make life safer? Yes, do things as much as you can outside. And when you can't, bring people in for the time that they need to be inside. Yes, it's relevant to risk, but I'll tell you something about testing and tracing. It only tells me what happened yesterday, the day before, 2 days ago. I'm interested in protecting you for today. So if your patients get all, you know, narked about, oh, how come you're coming out to my car? Just remind them that we're in the middle of a global pandemic. We love them to bits and we're going to see them regardless. And so that's where I was going to sort of deal a bit with today. So I've actually sort of said less cleaning, more air. So that gets to one of the points. We're not getting really strong evidence that we're getting transmission off surfaces. That's not our strongest evidence. We've got far more evidence now about air and not getting decent ventilation, which we can, do something about. But cleaning, yes, sure. Wipe over your high-touch surfaces each day. Just a detergent wipe's enough. Please no sprays. We're not using sprays. We don't want stuff going everywhere. So that we've not backed off, but it's dropped a little bit. Cleaning's still important, and I'm sure clinics have never looked, better. But basically, don't have chairs with armrests. Don't have doors that require, manual opening. The less touch points you've got, the better. Okay, doors open, etc., etc. Don't worry about privacy, please. Things, we need to move on a bit. So hopefully I've given you a bit of a clue there. Now, Charles, do you want me, any more questions have come up, or have people just zoned out and they're thinking about lunch?
Perhaps they're eating lunch while they're listening to your expertise, Mark. We've had a few sort of different questions on different topics, but I guess I'll try and pick one that's maybe most relevant to what you've been talking about now. And thanks everyone for sending in questions. We will have time at the end as well. But just on the topic, we've had a question around, do you know, Mark, if it's a requirement for general practices in a hotspot area or outbreak area to wear an N95 mask when seeing patients for any reason, such as a vaccine clinic?
I can tell, look, number one, the chief, Purifiers who write the rules talk about risk assessment. Now, if there's something that drives me crackers, because I'm not very good at, at this, I like to kind of know, how can I get in and prevent? I'm really big on that. So you might grade me as somebody who's over the top, but I tell you what, I just don't want to call from the contact tracers to say there was somebody sitting in your clinic yesterday and by the way, you've got to close down, spend $6,000 or whatever on a deep clean and get everybody tested. I'm actually not interested in that. I'm interested in you seeing your patients in the safest way we can present as possible. That's what I'm interested in. That's the space that I'm working in, I hope, for you. I can't make life 100% safe for you, even with the vaccine. But what I can do is say, or looking at people sitting in the waiting room, let's not do that. I can say, does every patient need to come inside to see the doctor? Or do they need to sit in the doctor's surgery for 20 minutes and there's 32 people and eventually you're going to get somebody? Can we do any swabbing? Can we send them off to the swabbing station? You must have millions of swabbing stations. I would avoid doing swabbing. If you're doing, and they might have to go to hospital, some of them, because they're crook and they can be swabbed there. For your vaccine clinic, can I run my vaccine clinic in a marquee? Yes, you can. So the pandemic, I go back to that original model. The pandemic asks us to be more creative. It doesn't say stop delivering medicine. It says find a more creative way. That's what I'm trying to bring to you. So I know that for probably 3/4 of you, you'll say, I can't do everything that you've suggested, Marg, but yeah, I can do 1, 2, 3, 4. But please don't focus it just on PPE. Can I say with PPE, it's mask and face shield. The type of mask that you wear, and gloves obviously, the gown, I'm sorry, I'm a bit slack on the old gown because we have not found, in certain circumstances obviously where I'm doing massive testing, but where I'm just doing something from, this person and that person 3 hours later, we haven't got strong evidence that the gown is creating, that we're getting transmission off the gown. Now that comes from the 2009 flu outbreak, I'll be honest. It doesn't come from work we've done now, but you would have seen in different countries, they're just wearing aprons. So you can begin to see that the gown, how unrealistic would it be for me to put on a gown for every single patient? Ridiculous. First of all, I'm wanting to see a lot outside and some by telehealth and some inside, but I'm not actually going to be seeing symptomatic patients inside, and we are going to have a fantastic screening system. We also want the patients to declare symptoms because we're going to say to them, we want to see you, but it will just be about whether we see you in your car or whether you come inside. That's all, because I worry that patients won't declare symptoms because they think that they're not going to see you. And we need to see them for lots of reasons. Now, what was the original question?
So it was, are you aware, is there a requirement for general practices in a hotspot area or outbreak area to wear an N95 mask when seeing patients for any reason, such as a vaccine clinic?
All right. Look at the hospitals, number one. Are they wearing P2s? I think the answer is yes. Me, if I have got good trust in my frontline staff, my staff at the front and patient symptoms, etc., and I'm in a very low risk area, I'm fine about ordinary masks. But I tell you what, things are stepping up a bit your way and I'm a little bit keener. However, if I then look at that risk map, it says if there is a high risk. Well, I'm sorry, I think your area, the Central Coast especially, it's looking high risk to me. Looking high risk to me. And I don't think I'm really stepping out of line, but for the sake of, rather than wear a P2, why don't I see as many patients as I can outside with a surgical and an eye patch, I was going to say a face shield. So look at all the risk reducers with engineering and administration and rely on your PPE last. Hopefully I'll put PPE in its place. But if we're just not asking questions, if we've got them all 1.5 metres apart, no. So come on, I want you to tell me what changes you're making from this afternoon. And the instant you say, we're okay here, I'm worried. Because you're only talking about the figures you see from today, and I'm telling you, you don't know what actually happened 2 days ago that's going to show up. Remember, it's 24, 48 hours till the test results come through, and then another 24 hours before the contact tracers contact you.
Mark, that's just yeah, I think that was great. Thank you.
If I'm sticking my head in somebody's car and they're symptomatic, but I've got to check their, oxygen saturation, I've got a P2 mask on.
Yeah.
Okay.
And just one more question, because we sort of touched on it a bit, Mark, before we move on. There's a question around COVID vaccine clinics in practices. So Suze has the question around, what would you suggest with running a clinic, but the car park's not big enough? How would they run it? For example, with the waiting room, you were considering what you were saying about waiting rooms, when obviously patients would need to wait 15 minutes after their vaccine. How could a smaller practice manage that?
Okay, well, the smaller practices tend not to have as many patients coming for the vaccines, number one, but think about outside chairs with the door open so you can see. That's what they do at my clinic. Just, your principal thing is, we know that of those cases of anaphylaxis, I think all but one occurred within, what was it, 11 minutes, the few, they did it on a small group, I know, but they all occurred within 11 minutes. And also, I have to say, nothing wrong with saying to the people who are sitting there, can you also keep an eye on each other? Because although I've got half an eye on you, that's what we do. It's a pandemic. We look after each other as well. So we've actually just opened up our first drive-through vaccination clinic. And if it's any help to you, that's exactly what they're doing. They're just keeping an eye on the cars, which you might think is a bit hit and miss. But a pandemic asks us to look at things a little bit differently, not be sloppy and slack, but even, I think, using our powers of observation, to really good effect. So with your vaccination clinic, you might conduct it, as I said, like ours is, just inside the treatment room door, and then, goodbye to the patient, you're sitting there, and as you call the next one in, you can sort of see everybody. So there's probably, 1 minute off in between every, while you're doing a patient that you're not observing. So yeah, just sort of think about what is reasonable, but I do have to observe the patient, for the 15 minutes, but nothing wrong with asking the other people to help you out there. Often they come in couples or families as well. And tell people what to look out for. Obviously, if they fall off their chair, got a problem.
Cool, thanks, Mark. We'll leave questions for there now, and we can come back to some more in a bit.
Yeah. So less cleaning, more air. Think about now how I can get oxygen. I would want that plus symptoms at the top of your list. So Charles, I'm wanting people now to type in the changes they're going to make, or they might say to me, oh, we're better than you. We're doing 100% of that and more. I want people to tell me what was the most useful bit of info. I'll need to make sure they got it right. But what was useful in that, 50 odd minutes that they go, oh, that's something that we can do. It doesn't cost anything. Don't laugh, but the last time I did this, everybody said a coffee machine in the doctor's rooms, but we've got to move on. But that idea of being able to use the treatment room with the 3, cubicles. Some of you I know have only got 1 or 2, but everybody's different. And people find a way. Sometimes people actually convert one of the doctor's consulting rooms on a daily basis to an extra treatment room because there'll be no doctor in that room. But I'm most concerned that doctors and nurses need a space, and the receptionists, they need a space to have their breaks and not have that mask on continually. For the receptionists and nurses, it may be the car or a spare room or something, and for the doctors, it may be their consulting room where they're not actually seeing patients in there. But I can tell you all of these are in the mix, and all of them I've observed. All right, do you want to move on to the 50-question quiz?
Did you want me to read out some of the answers, Marg, that people are putting in the chat?
Oh, yeah. Okay, let's do that because, they're probably just wiping their mouth now and thinking about getting back to work. But I am providing for Charles a whole lot of questions to 50 questions that he sent me yesterday, just in case I might know the answer.
Just for consideration, yeah.
Okay. What did they say they're going to do?
So I'll just read out some of them, Mark. So opening doors in reception, promoting breaks for staff. It's a reminder that the pandemic demands that we think of things differently. Minimise face-to-face time. Could send them out to finish a consult by phone. Less people in the waiting room. Fresh air, telehealth, car inspections. Have a break in the car, no coffee room. Considering having people outside post-vaccination. HEPA filters have been purchased.
Woo-hoo.
There's lots and lots, Mark. So yeah, everyone's getting a lot out of it.
So the point of me asking is that for those of you who've been too frightened to type anything in, can you see? We're on board. So nobody has said, I hope, don't read that one out to me, nobody has said, we can't do any of that. We can. And we will. And this is to me, this is an exciting time as well as being extremely stressful. But this is about really understanding something that has affected humankind for a long, long, long time. And there are things we don't understand. What is it about these little kids? Listen, when I watch those 2-year-olds drooling, I kind of see lysozyme and interferon maybe. I see all these goodies in that snot and I go, what's a virus? I don't think I could get a grip on the throat anymore with all these antiviral goodies. Maybe we should be putting that in a test tube and selling it. I don't know. But I think with the kids, my hunch is that their infectious time might be shorter. They've got fantastic little immune systems. They seem to be clearing this virus quite really quickly. So my hunch is they might, instead of having maybe a 6-day infectious period, a couple of days before and 4 or 5 days later, because most of us clear the virus within 5 days, unless you, go down like a ton of bricks. And in that second week, it's been an issue, hasn't it? And that is, your T cells going a bit stupid. And can I just say, going back to T cells, to me, T cells, in terms of immunity, I think, are probably going to be more important than antibodies. So you know that your adaptive immune response has got the T cell and B cell response, and you have your second dose, your boosted dose, prime dose, etc. So we haven't been able to really measure a lot with T cells, but for viral infection, T cell response is actually probably more important than antibodies. Antibodies we can measure, they're just easier to measure. T cells are a bit tricky, but can I tell you about the T cells? And I reckon these little kids have got fabulous little T cells because the T cell can tell when the cell is infected. Your poor old antibodies have got to wait till the virus comes out of your cell before they jump on it. So I think T cells are going to be the secret here. All right, enough of that because that's a little bit of, speculation there. But I'd be really happy if people went back to a bit of a reread on your innate immune system and your adaptive. So don't discount T cells. I think they're more than 50% of our immune response here, our helpers, our killers, our suppressors, but we do know they've had a bit of a bad rap with what happens in week 2 with some of our patients where their T cells just go a bit stupid and cause this ridiculous inflammatory response. So will I go on to the questions, Charles?
Yeah, that'd be great, Mark.
Okay. Is there a list of private organisations providing fit testing? Well, I'm going to put it right back on your PHN because I was told this morning that the PHNs, I think, if I've got it right, are supposed to be or could perhaps be organising that. But I've shown you how to put and do a fit check. Don't wait for the fit testing if you need to be using your P2 respirator masks. I've shown you how to do the fit check. And I can't tell you how much difference it would actually make to do a fit test. I can't quantify that for you, right? We don't know. The second one was gloves or no gloves. And I'm wondering, do they mean when you're doing a swab or do they mean immunisation? I think you mean immunisation. And of course, you've all seen both. So when you're doing mass immunisation, you tend not to wear gloves. All right, you've got in terms of risk, you've got a small bore needle. You should not be going into a blood vessel. And blood, of course, is the riskiest fluid. And so that is the logic. And yet for me, it's counter, intuitive because we've always taught around sharps wear gloves. And so I find in general practice, they do tend to wear gloves because they might just be doing one immunisation here and there, unless you've got a clinic going. So I think when I had mine done at an immunisation hub at the Repat here in Melbourne. I can't even remember. I noticed I got a Band-Aid the second time. Oh, not a great look, everybody, to put the Band-Aid here and then put it on my open wound. Not fantastic. I wouldn't be accepting that. I don't think you need to have Band-Aids, etc., etc. So then the next question was, any thoughts on UV sterilising? All I can say about UV sterilising is that it's got very poor penetration powers. So if you've got a surface that hasn't been cleaned, I wouldn't be worried. I wouldn't be using UV on it, and it wouldn't be where I'd go first. Okay, I'd be definitely doing my engineering, my administrative to reduce risk, and then my PPE. Obviously, good cleaning daily. Number 4, what PPE is recommended for staff at a GP vaccination clinic? Face, and if you're wearing gloves, your gloves. Can't get really excited about the gown. Sorry. I think I've given you some thingos there. You shouldn't really be getting splash and stuff like that. And your patients need to be low risk. Next one, is there any intention to have wider ongoing community education on viral infection and when to attend healthcare or consider telehealth? I can't answer that. That's up to you guys. Next one, should GP staff on the Central Coast be doing COVID swabs regularly as a check measure? Did you mean surveillance of healthcare where we do, say, the rapid antigen every day? Be careful. The rapid antigen, all I can reiterate is that there are lateral flow tests, they're called. There are rapid tests and rapid tests. And really, our PCR is as close to gold standard as you can get. Your turnaround time, yes, it may be up to 48 hours. Ours is down to 12 hours, which I'm pretty knocked out about. But we're doing maybe half or less of the swabs you're doing. But the only reason why we're better now is because of what happened last year. You need to learn from us. I did the wrong thing, could have done it better, etc., etc. But now, hopefully we're in a better spot. I don't really like the GPs doing COVID swabs. It takes a lot of time. I'd definitely be checking my patient before I send them off for a swab. If they're not well, definitely see them outside. But I think you're actually talking about staff. So what they are doing is in the food industry, and I think in aged care in Vic, the public thing, they are doing what we call that sort of, it's a bit more than surveillance, but it's sort of surveillance. But I don't think they're doing it as a rapid test. They're getting the results within 12 hours. It's giving us a picture. What's going on in this community? What's going on in the food transport area? What's going on in aged care? But I think that they are the PCRs. And in fact, the pathology is right to the aged care and say just order up as many swabs as you want and you'll get your results, later that day, early the next morning. That's pretty good surveillance. With the rapid antigen, this is the problem. If you get, and there are false positives, if you get one false positive in your staff after a week of testing, you do it every day, where does that get you? Because a PCR test would have told me that it's a false positive. And I know I'm on sort of slippery ground here, but if we only did rapid antigen testing, that's not going to be helpful if you start to get these false positives. And even the PCR being 99.95 effective against what they kind of worked out as a gold standard, you know, as 100%. Even that is missing the occasional one and making the occasional one positive. That's, you don't want it any worse than that. But the rapid antigen is dependent on the type of swab. You know, was the swab taken properly? And I know the PCR is the same. And also it's a little bit more dependent on, was the patient producing a fair viral load? So the rapid antigen test may not pick you up 48 hours before you develop symptoms. It might pick you up 12 hours, it might. And it may not pick you up 4 days into your illness. And so if you're doing it frequently, every couple of days, that's more helpful than just doing a one-off rapid. But they're expensive, they're about $45, or the ones I've seen about $45 each. So don't let anything take the place of the engineering aspect, you know, with the air, the questions, you know, the admin stuff, and then just using my safe spaces, you know, my outside, all that kind of thing. But really getting into my, you know, the best barefoot medicine that we can do, and that we want to see all of our patients. We don't want to miss heart attacks, strokes, you know, all that sort of stuff. We don't want to miss that. Do face shields count as eye protection? That's exactly what they are. So for me, I wouldn't bother wearing goggles. I'd wear my mask and my eye shield. One little tip, when you're wearing your, and I'll do this the wrong way around, when you've made that, to stop your glasses fogging, sit it really tightly, just nicely on there. You won't get fogging. You won't get fogging. And then over that, okay, and whenever you take this off, you only ever touch from the end, and when you take it off, you can wipe it backwards and front. It's yours. You can pop into a Snap-Lock bag, that's yours. Wash it out at the end of the day, but you can certainly wipe, you know, back and front. So just to sort of take that off. Do I need to shave my beard off? Yes, if you're wearing a P2 mask. How do you prevent eye protection from fogging off? Don't use goggles. Okay, and I've shown you how to put your glasses on and stop them fogging up, and how to use your face shield. Someone says, interesting article from The Lancet, touches on social and cultural issues. I shall read that, about PPE. Number 10, is it not the case that if you are a casual contact, you have to isolate and get tested no matter what kind of mask you're wearing? Yes, until, and this is what, this gets to, I think, what a lot of us go, why do I have to close down for 2 weeks? Can I tell you that the initial instruction is, you've had a positive case, we want you to do this, this and this straight away. That is test, close, and whatever the other thing is, like, oh, find all your patients. Then there's the deeper questioning, which comes a little bit later. So you can see we've got to do that urgent stuff. And so this is where now the health department will chat to you and say, can you tell us your situation? And this is the position I want you all to be in. I want you to all be so full of, we don't use our waiting room, patients only come inside if, you know, if they're not symptomatic and blah, blah, for the shortest time. If a doctor's got to see a symptomatic patient that got P2, believe you me, I won't bet a bottle of French champagne on this, but I can tell you, you're in a whole lot better situation for not closing down for 2 weeks if you're doing all those things. And if you said, it's okay, they'll contact me if we've got a positive. It's a disaster if you've got a positive, you know, for you and for your business. So, you know, that's sort of where that's getting. Anti-fog lens. So actually going back to that person who said, can you please formally ask the New South Wales Health about this question? I'll give you the answer, because I know they then go into the details the next day. Once they've got your results, they'll then go, now what were you doing? How were you running your clinic? Does that make sense? You get that sort of questioning. Anti-fog lens cleaner. Oh, look, just don't use goggles. Okay, use your face shield. Do we need to leave our surgical mask on when doing telehealth alone from a private closed room but in the workplace? This again goes to that space that I think you can work in nicely and not see patients. How about that consulting room, if you can, just doesn't have patients in it, if you can. If you've got to have patients in, can I do them in the afternoon and do my telehealth mask-free in the morning? Can I do that? But this thing can hang for hours. All right, again, you'll say the risk is quite low, Mark, because we do A, B and C. Fantastic. So you might say open windows, see the patients, in the afternoon, telehealth in the morning. Don't have to have the windows open. It's just me in there doing all that. What I think it would be a disaster would be to going from 2 patients to a telehealth, 2 patients to a telehealth. And what do I do? What do I do? Is having the windows open enough? I don't know. So no, I hate you having your mask on when you're doing telehealth. So try to get that room that it's just yours. Number 13, is spirometry still working? Oh, please don't do this. Okay, either send a person to hospital where they can do it in a negative pressure room if they're that crook. I wouldn't be doing it. Oh, do it outside. And don't laugh, because lots of us are doing medicine outside. Number 14, should the GPs and clinic staff in our area start regular surveillance screening? Would that help avoid isolation and cancelling clinics? So that's going back to that thing of the rapid antigen testing, or perhaps you can get a deal where you can get a 12-hour turnaround, good luck, with your PCRs. But if you're doing the rapid antigen, I would really want to be seeing that being done heaps, not just one-off. Remember what I said, we need to catch you when you're infectious and not just do a one-off. I'm just very cautious. It's definitely got a place, the lateral flow, but honestly, a false positive can just upset your whole week. Okay, don't want to do that. Number 15, any advice as to the best HEPA portable air filtration unit to purchase? Well, I haven't got shares in Samsung, but anyway. I can't remember the brand. I'll send that off to Charles with the letter on the type of P2 mask that they're having a bit more success with testing. Number 16, if we're doing swabs in the Armidale area, should we be wearing a P2 as well as eye protection? I hope you're not doing your own swabs. I hope people are going to the testing station. So unless this person is at the testing station, which I hope is outside, I'm not as excited about the P2. I know you've all heard about fleeting contact, but sometimes I think there's a bit more of a story than what we're getting. You've really got to inhale an infectious dose, and that really is a few thousand bits of virus. So outside with a bit of air movement, in those tent things that you drive through, I can't see that. In fact, can I just say, somebody at one of our testing stations tested positive last week. Guess what they were doing? Ride sharing. Where do you think they got that from? Don't start me. How long will the aerosolized particles last in the poor airflow? Hours, as I've mentioned, a typical doctor's surgery room. So hopefully I've made the doctors think about how can we reduce that hanging, that suspension of the particles. I'll be really happy if I've been able to convince you that we just don't need this air laden with particles, because your surgical mask will not be enough. And who wants to be wearing a P2 all day? No thanks. So how young should we request children to be COVID tested? Well, I'll tell you something about testing kids. I think you can do the spit test. I think they sorted that out at the Doherty. They provided like a spit test for little kids. My grandson had a back of the nose done a couple of weeks ago, and he said he liked it, which makes me think it probably wasn't. And they don't really have to go as far back as they used to. But this is what I would do. We want to know what else is running around the joint. So rhino, RSV, any flu A, flu B, and don't tell me there's none. There is. Okay. So I'd hope that when you are doing a little kid, get your money's worth and get a panel tested. At 3 months, I haven't got figures on the little bubbers, whether they're getting it, so I can't help you there. What plans for the workforce if contacts of contacts shut down? Rapid testing, and that is the space that rapid testing can work in, and I think that they're doing that currently for the food transport industry here at present. But I think you can see why we ended up doing that, because we had those meat production plants closed down. It was actually spread from the manager who was, at a cheese and wine function with some overseas people, brought it into the factory, and hundreds of people. This is last April, May, in Melbourne last year. Thanks for nothing there. And it does mean not necessarily close down for 2 weeks, but we say 2 weeks because we need time for everybody to be swabbed and for the contacts to develop. Okay, so getting time, that can be the 14 days. And of course, if you develop your infection, on day 6, then you're obviously going to have to, quarantine for a bit of extra time there. But yeah, rapid testing does have a place. Just watch this space, but just a one-off here and there, I'm a bit terrified of. I work a bit with the ACCHOs, the Aboriginal Community Controlled Health Organisations. They do offer it before the patients go into the clinics, and so they tend to sort of offer that as a one-off, but it's for other reasons as well. Can open plan emergency departments any number of metres from the patient? Is that acceptable? Well, sometimes you just got to see your patients, and you've got to be near the equipment, and outside is not an option, and having 1 patient per room is not an option. It is called taking a risk, and you've got to acknowledge that. So you go, I'm taking a risk, but I'm double vaxxed, I'm using a P2 mask, and the patient is in here for the shortest time. So you see your risk reduces, but you cannot eliminate risk in that situation. What about single rooms without ventilation? I think you've heard me harp on enough about that. The role for the ambulance bay, if you've got equipment out there in the ambulance bay and you can do some stuff out there with the air open, fine. But, some of the equipment they need in ER, it's not really that transportable. So this is about saying, here is my risk. I can mitigate it to a degree, I can't eliminate it. Tough. We're turning the bed so the patients facing away from incoming staff in ED rooms and examining from behind have much additional, but we're trying hard, aren't we? I think that limiting the amount of time, contact, definitely the further back you move, if there's good ventilation. Okay, if there's good ventilation and move back. So you do it all. You don't just walk into a place and say, oh, they've got 6 air changes an hour. I can get as close as I like. No, we use multiple risk reducers. It's not just one. And this is the way we have to move through this pandemic. Yes, I'm double vaxxed. Yes, the ventilation's good. Yes, I've got a P2 mask on, but I still stand back from the patient when I don't need to be close. Yeah. Where can GPs be fit tested? Ask your local PHN. We work out of small, windowless, unventilated rooms. I think you can advise that clinic. What does that mean for respiratory patients? I think you know. How long should we leave the room after a respiratory patient, after they've been coughing and even though they've got a mask on? It used to be 30 minutes to an hour. I think you might find now, if we've got no air changes, we're looking for another site for our clinic. Do you need safety glasses and face shield or only one of them? Face shield is fine, face shield with mask. Do we need to wear face mask and safety glasses or one or the other? You wear a face mask and a face shield. I prefer the face shield to the glasses. They're having a bit more of an issue with that bump on your nose with the goggles. You won't see many people using goggles now. With masks, is there any benefit from double masking? You see that that's done in America, but it hasn't been quantified as far as I know. If you only have surgical masks, make sure that surgical mask is flat on the side of it and no gap. Almost use your glasses to sit on it. And if you're using a P2, same idea, you've done your fit check. So I don't know about the benefits from double masking. I've seen it, okay? But you've got to have your seal. You can't wear a P2 over a surgical. Can't do that. Do we still do temperature checks if we have to get close to the patient? You do your temperature checks even if you don't have to get close to the patient. Versus automated infrared. The infrared check. I think there was some not so great information coming through. I'm sorry, I'm not going to comment on that. I think it had some downsides. What about the suggestion that a cloth mask over a surgical mask if you can't access P2? Go outside. You know what I'm saying? Let's look at other ways that we can reduce risk. Because of PPE supply limits, one doctor found information about cleaning and reusing PPE. Yes, I've seen that about washing the masks. Not great. We don't have to do it. With the gowns, you see that you can wear your cloth gowns and wash them. A lot of you will be wearing scrubs, which is fantastic. I prefer you not to wear them home and just rinse them out and hang them up overnight. There you go. There's a bit of occupational therapy. Don't wash masks. All right, we just, they've even looked at sterilising them and stuff like that. Don't go there. But we do have plenty of masks. And wash your face shields, but you can wear cloth gowns in a low risk setting, low risk. Morpeth, maybe. How are you minimising people in the waiting room given 15 minutes post-vaccination wait time when vaccinating 150 an hour? Well, thank you for immunising 150 an hour. You know what my answer is going to be. It's going to be outside. What you've always got to look at is the risk. So if you must have a big waiting room, 15 minutes post-vax, 150 an hour. So how many are in that room at any one time? That's a lot. That's either a big waiting room or they're crammed in. So let's think a little bit more about that. Was booked in today for fit testing, but the company told me they were told they can't do respiratory fit testing with current restrictions. That'd be right. Outside as much as you can, okay? But have some confidence in your fit checking. Have some confidence in that. It's the best we can do at present. Regardless of all these precautions, if you have a patient with positive test, you're closed for 2 weeks, right? You start to close for 2 weeks, all right? And then, as I said, the department will then discuss with you what were you doing to reduce risk. And so a lot of you will get a nice, pleasant surprise if you've been doing all the right things. But God help you if you've just been waiting for them to do all the work, because it's not pleasant what you have to do. Are we at the stage where we should be testing the healthcare workers weekly, regardless of exposure? That goes back to that regular rapid testing. So I don't know how that's going to pan out, whether they're going to do 3 times a week with a rapid, or whether they're just going to cycle through a clinic, which is what they started to do with aged care, so that 25% of staff got tested every 3 days. So you can imagine over a fortnight, and we cycled through that. Then we kind of stopped doing that because we had no cases, didn't we? Now it's back. Is it necessary to use an N95 for non-ARI, acute respiratory, I think that means? Is it necessary to use for non-respiratory patients? Do you mean patients who've got no symptoms? That is that whole risk management. Best way to reduce risk, see a patient outside. I'm comfortable with people wearing a surgical mask outside. But come inside, then now I've really got to think about how long am I going to see this patient? Is a surgical mask okay if they've got no symptoms? But what if it's only after 3 minutes with them that you go, my God, they do have symptoms. We've not declared anything. So that's a hard space to be in, but I don't want you wearing P2s for 2 hours at a time. Curious about the use of wraparound glasses or goggles for those who use prescription glasses. Face shield. I work for an NGO, residential 30-bed unit. We utilise P2. How do you recommend fogging procedures? No, for all areas weekly. Bunnings have got the shields yet. So no, I wouldn't be doing fogging. Okay, just really good ventilation and stuff like that. See, some of you are at the mercy of people trying to flog your stuff. And that includes the rapid antigen, and be very careful, because I think there are maybe 10 top brands that some of them are just no better than 90%, and we don't want that. For patients with acute respiratory infection who present wearing a cloth mask, we would prefer them to change into a surgical mask. Yes, absolutely. At the immunisation clinic that I went to, the hub, you immediately discard your mask if it's disposable into a bag, into the bin, and if it's yours, they give you a bag, I think, and they do your hands, put a new mask on, do your hands, and then go and wait for your immunisation. So absolutely, yep. And I know it means you'll be going through heaps of masks, but who wants a case? Where do we purchase the eye protection glasses? Shields. I want you to do shields. You can have goggles, but they're just, a bit trickier. The patient, should they put the surgical mask on over the top of their cloth mask? Get them to take it off to avoid handling the mask. But you heard what I said about hand hygiene. If reception are behind a Perspex screen, would you also recommend eye protection? And that's going to depend on risk. They've definitely got a mask on, but there's only one of them in reception, not two. So, they shouldn't be a risk to each other. And the patients aren't sitting in reception, are they? In the waiting room, are they? So we need to reduce risk rather than just give people more things to wear. Can we have clarification on whether to use P2 masks during regular consults? Right now, as a GP in Newcastle, I'd be seeing as many patients as I could outside. And where I've got to have, where I do see people inside, I'm going to have to make a decision on where this thing is circulating as to whether I wear my P2. Me, I've got a P2 mask on. That's me. Okay. Right now in Newcastle, I've got a P2 mask on. As a trainee, is it possible for me to request only telehealth in the first instance? Yeah, I think that is, it's to triage patients. Well, yeah, but you need to be quick about it, I think. I've had a few patients not mention respiratory symptoms and wear masks inappropriately. Yes, don't they? So you need to be the best, before you come in, can you just pop your mask on over you? Have you been given a new mask? Have you popped over your nose, please? Pinch it. Do your hands. Right. Now you can come in and see me and explain your angina. Right. Also, as GPs working in the front line, is it appropriate for me to request my household contacts be vaccinated by my practice? Yeah, because this is all a part of the healthcare community, your family. And you heard me ask, please ask your family, anybody with symptoms. You've got to tell me, because I can't go to work today if one of you guys have got a sore throat. The old days of turning up crook are over, and that meant also your household. Vaccines are hard to access. Well, hopefully there's lots of, AZ is a very good vaccine, very good vaccine. And also you guys are very skilled at telling patients what symptoms to look for with that, the special clot, the TTS or whatever it's called. I feel that we will have less people ending up in, really bad situations, the more we can get that information over to our patients. The AZ is a very good vaccine. And I'll be outside the square here. I'm looking forward to seeing, because, the immunity is increasing with time. I mean, they stopped the trials because they had good information. It's actually increasing. So I'm interested to see, with countries that immunised early in January with AZ, I'm looking to see whether there's any breakthrough cases for them this winter. And I know some of them are gearing up for the third shot. The Pfizer are, but Pfizer were very early in Israel. And Pfizer, I'm looking forward to sort of seeing the results as to which one. It wouldn't surprise me if the AZ gave me a longer protection time. Wouldn't surprise me. I'm not telling you it will. If one of our patients become positive for COVID, what strategy should be adopted? I think you'll be called. And actually, as private industry, you, in fact, may be required to call all your patients. I know that they do that with some private places. They don't list it on the website, and it's up to you to sort of contact everybody. So I can't tell you what exactly would happen in your area at present, but just reduce risk by using as much of that as possible. Now it's 2:30, I think we're done. Charles, I hope I haven't sort of misled anybody or killed anybody or whatever, but I think you'll find that everything I've said does fit within the guidelines. We've just got to be a bit more creative about the way we do it.
Yeah, wonderful. Thanks so much, Marg, for taking the time to answer those extra questions that we've had come through. I thought if you're happy, there's just one final question that I thought would be pertinent to ending the session. It's a good question. It's, where was it? Is COVID going to stay in the world permanently?
They've been looking at where it has been over the last, 20, 30 years and how it's been, gradually modifying itself. Some areas of the code are conserved. So I'm actually thinking that we'll get a vaccine that'll cover us for really most of the coronaviruses, even though, look, this thing, the reason why there is a race to immunise, the reason why, is that every time it passes from me, or it passes from me to you, or, your mum to your dad, whatever, every time it passages, that's the sort of term that we use in virology, it alters a little bit. You can call that a little mutation. And then eventually you can get quite a branching, a decent mutation. So that's how we can track where I got mine from, because I tell you who I've been in contact with and they go, oh yeah, you got yours from, from that clade. The clade is there, that's similar, and she got it from there, that's similar. And then all of a sudden you get a big branching away, you get a decent mutation, and that can result in, say, Delta or something like that. But what they found is there is a part of the virus that is conserved and stays the same. So we're going to be after that vaccine, a refined one, and there's still lots of vaccines in the pipeline, but we're looking for that vaccine that we can use universally for corona. And, the virus had a bit of a first go in 2003, 2004 with SARS-1, and then, of course, with MERS, the Middle Eastern Respiratory Syndrome. But now it's mutated and mutated and mutated. So what the virus does is it needs to go very easily person to person. That's its aim. Its aim is, I won't say survival because viruses aren't alive. They replicate. Just as you can't kill them, you can inactivate them. So the other thing the virus can't do or doesn't work is if it kills everybody, because that then stops it replicating. So with our viruses like measles, you've seen them cause havoc in new populations, and then you get that sort of steady state where you get less death. You still get serious illness and you still get death, but it's not in the virus's interest to knock everybody off. So with COVID, the race is to immunise so that we reduce the risk of mutations. That's, as a microbiologist, that's all we're after. Because the more this thing goes person to person, the higher the risk of a new mutation that favours, a big mutation that favours even more, more easily the spread. See, most mutations to the virus are lethal to it. It goes nowhere. And we've been seeing that with bird flu. When bird flu, I think it's, the really nasty one, when that gets into humans, there's like a 20% mortality, but it won't go human to human. So the virus sort of learns, I need to go human to human. So maybe some of my pathogenicity drops off and I don't kill 20% of people, that I infect. So there are two things. There's an evolutionary pathway, if you like, where the virus will become less of a problem, but also the host develops a better response to infection. And that's what you look to. But I can tell you that there are practices changing where their location is, because they're seeing the shortcomings of being on the 12th floor of somewhere where they don't even, the patient's unquestioned until they've used the lift, gone to the coffee shop on the way. Okay.
Wonderful. That was really interesting there. Thank you for sharing that. So thanks so much again, everyone, for joining us this afternoon and sticking with us. Thanks for sending in your questions, and take this opportunity to thank Marg for spending her lunch with us and giving us such important insights in the current climate, particularly in our region at the moment, with everything COVID. So thanks again for joining us, and just a reminder that the session is being recorded, so you can access the recording in our PHN Education Library in our website from late this afternoon. An evaluation survey will pop up as the webinar ends. If you could take a moment to fill that out before you log off, we really appreciate your feedback. So thanks again, everyone, and we hope you have a great afternoon.
Okay, thank you.
See you later.
Bye.